Good afternoon, everybody, and welcome to another edition of the New York State HIMSS Chapter and our virtual meetings. Today, we have a webinar that'll be discussing ONC and Health IT. And later on, the second half of this, we have the folks from CMS will be also chatting with us. Next slide, please. For those of us that are out there on the attendees, we have live captioning available. So if you need it, touch the CC button, and then you'll be able to see everything pop up on your screen. For any questions that you would like to have our panelists respond to, click on the Q&A function up on the top right-hand side, and then put your questions in. We'll have somebody who will be monitoring that, and then we'll be able to direct them to our presenters. If you run into any technical difficulties, just click refresh when you're viewing in the web browser, and we'll get you back up and running again. For those of us, as we have been doing in the past, this event will be recorded and be available, hopefully within 48 hours, on our YouTube channel and up on our HIMSS website. Next slide, please. This is another good reason why you should become a member of HIMSS. This way, come and join us. Here's our event calendar. You'll see, click on the New York HIMSS chapter.org site or scan it on your camera phone and you'll be able to join our chapter. Next slide, please. Okay, let me turn it over to our first guest, Mr. Steve Posnack from ONC. Steve, thank you for joining us. Have a great time.
All right, thanks very much. You can hear me okay? All right, I'm going to assume that you can hear me okay.
Yes, we can hear you fine. Thank you.
All right, awesome. It says unmute my mic. So you never know. We've been doing this for what, 15 months now. Appreciate the invitation to come and speak to the New York HIMSS chapter. I happen to be a native New Yorker, born and raised on Long Island. So if there's ever a chance to come back and visit you all in person, I'm happy to do that too. But thanks again for having me. As the introduction so indicated, I serve as our Deputy National Coordinator at the Office of the National Coordinator for Health Information Technology. I'm going to do a little bit more about where we exist in HHS, the Department of Health and Human Services, in just a bit. But I serve as the Senior Career Official as part of the office. So in just a few weeks, it will be my 16th year of service with the office, now on my 4th presidential administration. And so lots of history to cover. I happen to have one slide just for Nick, who's going to be advancing the slides today. Slide number 5 has lots of animation on it, and I apologize in advance for torturing you through that. But let's go quickly to our agenda here. Thanks for pulling that up. I'm going to give you just a lay of the land in terms of ONC, my office. That's the acronym that we go by. If you haven't heard a lot about us, I'll give you the quick introduction and what we do and what we focus on. Wanted to make sure that you all were aware of the 21st Century Cures Act final rule and how it may be have impact in your work and in the work of your organizations, and then just talk a little bit more about what's cooking, some reflections on the pandemic as a whole thus far, where we can do better from a health IT perspective, given experience that we've had over the past year, and other things that you may want to be as aware of from a health IT perspective and how to get engaged with work that my office is doing overall. So let's go to the next slide. So briefly about us. As I mentioned, we're part of the U.S. Department of Health and Human Services. We're what's called a staff division in HHS speak. We have operating divisions and staff divisions. The staff divisions are those that are part of what are called the Office of the Secretary. The operating divisions are the bigger, I like to call them kitchen table oriented agencies. So they're the CMS, FDA, CDC, larger agencies that have bigger budgets, bigger kind of span of control, often in the news for various different types of aspects of their work. So brief history about us. We were created in 2004 as a result of an executive order that was issued by President W. Bush, as I like to call him. Then we were codified in law in 2009. And so the interesting thing here, as an office that was created originally by an executive order, had a new administration come in and, like they do with other executive orders, rescind it, my office, would effectively have faded away. But we were codified in law as part of the Recovery Act, and that is the law that you may be mostly familiar with as referenced by HITECH. That included the billions of dollars for the EHR incentive programs that our colleagues at the Centers for Medicare and Medicaid Services worked on over the past decade. And then my office worked on the various related components from a regulatory perspective for certification and standards and certification criteria attributed to health IT products. And that was a bit of a long churn of legislative implementation up until 2016. Right at the end of 2016, we had what was called the 21st Century Cures Act, and that included new rulemaking responsibilities, new authorities for ONC, and I'll cover those in a bit of detail for you. So you can go to the next slide. When you think about ONC, there are really three key activities that we work on, and that includes standards. So we work across the spectrum with standards development organizations like HL7, NCPDP, IHE, other ones at the semantic level, be it for SNOMED or LOINC or RxNorm, which happens to be stewarded by the National Library of Medicine. We do certification work, as I just mentioned before. That is regulatory related work that we do often to include and update our certification program over time. And then we look at the broad ecosystem of health information exchange. And so whether that is through health information exchange organizations like you have in New York, which is a rich and vibrant HIE as the noun ecosystem, and statewide investment that you're also beneficiaries of, or other types of ways in which people could exchange information, be it the national network, so Commonwealth, Care Quality, using SureScript free prescribing, all different types of exchange modalities that may be at different scales for data exchange, all the way down to patients getting access to their health information, that kind of N of one type of use case where someone may be seeking to use a third-party app or accessing their data via a web-based technology. So that's the work that we do in kind of that stack to the left there. And then as part of our middle name, you have us as the coordinator. So we do federal coordination across the executive branch on all sorts of things related to health IT, standards work, investment oriented work, new pilot programs, demonstrations. We do that across the executive branch. And then we also work at the state and local level and with nonprofit and other types of public organizations as well, in terms of executing our mission and making sure that folks are up to speed on generally what's going on at the federal level and how we can assist our partners at state and local levels. And all of that is really toward these two objectives that I have framed out there to the right that I won't name for you, but focusing on health IT use and how we can establish new requirements, bolster existing requirements to enable data exchange in the way that normal people think exists today in healthcare already. Nick, as you go to the next slide, you can just build it all the way out to 2021. It's a big timeline here. And I like to do this kind of reflection around how we got here and what all is going on. You start really at the left with the last telegram being issued in 2006, juxtaposed, I like to juxtapose that with the iPhone being released, which is really kind of a seminal event in our culture and our history and our technology usage, that you've got this powerful thing, it fits in your pocket, it could do all sorts of stuff. And in a health IT context, as you start to look across the timeline here, you've got Microsoft Health Vault being released, you've got Google Health coming out, you've got statutory and regulatory type work that came out of the federal government. You have product releases being ended there. So I'm at 2012 here, where Google Health was ended after about a 4-year stint. And then straight in the middle here, you've got FHIR, Fast Healthcare Interoperability Resources, that gets released for its release 1. You've got the Argonaut project, which kicked off, which is the group of health IT developers that sought to really push FHIR forward in industry. You've got, again, legislative changes between MACRA and the 21st Century Cures Act. And then if you look at that timeline again, between 2007 and 2018, took 11 years before Apple released a native app product into its iPhone as part of iOS 11.3, which is the Apple Health Records related software. That's that app that if you have an iPhone, you've got that now capable as part of your smartphone that you can use to download your health information directly onto your iPhone. And at the same time, FHIR Release 4 got released. So from an industry perspective, you see lots of iteration from a standards development perspective overall. Again, somewhat for bookends, you've got between 2007 and 2019, Microsoft ending its work with Health Vault, even though they've kind of pivoted to doing other work in the health IT space. Along that bottom part between 2019, 2020, and 2021, you've got the release of our Federal Health IT Strategic Plan for 2020 to 2025, and you've also got the rulemaking that I'll talk to you a little bit more in a little bit more detail about related to our conditions of certification and information blocking. So you can move on to the next slide, which is just my sorry, the one punchline there that I forgot to talk about, you don't have to go back though, is amidst all, thanks for going back, amidst all of the work that we've got going on, still got lots of faxing, right? And so you think about that and you look at all of the technology that we've put in place, all of the work that we've got going on, and still sometimes for default workflow, we're faxing health information, from place to place. All right, now we can go on to the next slide. Thank you very much. So you've probably heard about the Cures Act final rule. I'm going to give you the 10-minute orientation and distillation of everything you wish you knew and compress that into a few slides for you just to cover my bases for all of you. Let's go to the next slide. So there are two components for the rule that are implemented that we released last year, and that really implement and stem from two major provisions that are included within the 21st Century Cures Act. So you've got something called the Conditions and Maintenance of Certification, and those apply to health IT developers, and then you have something called information blocking. And so this is new regulatory authority that Congress imparted on to my office, ONC, and new scope for the responsibilities that we have as well. And so just to note that the information blocking provision is an entirely new body of law. Unlike the changes to our certification program, which come from the HITECH Act in 2009, information blocking is brand new. New kid on the street, and lots of work ahead to make sure that everybody's fully aware, first order, and then fully understanding the compliance obligations that Congress set in motion with respect to the law and its implementing regulations. One thing just to keep in mind, our rules came out alongside and often at times with CMS rulemakings that may focus on interoperability. And the one point that I wanted to make sure that was clear here is, especially with respect to information blocking, that is entirely an ONC related rulemaking endeavor, scope of rulemaking, and is kind of ours to steward and maintain over time. And while there may be other interoperability oriented rules that the department may put out, it is a specific ONC related obligation to continue to steward over time. And so when you think about information blocking, think first about the ONC related rulemaking paradigm that we have. All right, let's go to the next slide. One thing that I wanted to call to your attention that came out of this rulemaking related work is something called the United States Core Data for Interoperability. So this is a baseline set of data. It's required as part of certification going forward. And there are some milestones for health IT developers that are going through our certification program that they need to hit by the end of 2022. And I have a timeline that I'll cover in a little bit more detail for you here. But this will be data that will be accessible via EHRs, largely in a standardized form, although for the clinical notes there, that would be the unstructured data. But all of that is, again, going to be available vis-a-vis and really comes to life through two different certification criteria that we have. The summary care record certification criterion for transitions of care, which has a consolidated CDA as the payload or the data content and structure. And then equally, we've adopted a new FHIR-based secure standardized API that will also need to make available all of this data as well. And so those would be two things that you could look to see using for your organizations or for your work going forward as these regulatory requirements are hit from a compliance perspective. Next slide. So in a nutshell, the conditions of certification apply only to developers of certified health IT. So if you know of, Epic, Cerner, Allscripts, etc., that go through our certification program, for your knowledge and awareness, if you're not one of them, there are new conditions of certification that apply to these organizations as a business as a whole. And so there are certain requirements that we have now established in regulation that they need to meet. One of those, as I mentioned, is around application programming interfaces or APIs. And so they have a whole slew of conditions that are applicable to certified APIs that go through our certification program, including transparency requirements, certain conditions around fees, and certain conditions around pro-competitiveness and openness that they need to keep in mind as well in terms of engaging with customers and others in the ecosystem. Let's go to the next slide. So when it comes to information blocking, I wanted to leave you with 5 fast facts, as I like to describe them. And starting first at number 1, and I'm not going to narrate all of these, but just to give you the high points, Congress defined information blocking. So the way that Congress approached this was to say, there's something called information blocking, and here's what it means. And then Congress applied the law to 3 types of participants in healthcare. They're obviously specified there for your awareness. The other distinction and difference that I would call to your attention as well is, unlike the HIPAA-oriented law and implementing regulations, of which you may be familiar, the way in which this law is implemented is it's about the data. And so while there are these 3 categories of actors, as we call them for short, that are named in the law that are subject from a compliance perspective, the law applies to all of the data held by those entities that fit within this definition that we've established called electronic health information. And there are two important points here. Even though you may be familiar with our office from a certification perspective, the information blocking law is agnostic to the particular technology that is in play, and in fact, again, focuses on the data first. So when you think about information blocking, think about the data first, and then the systems from which it may come. And so the law doesn't distinguish between whether or not the electronic health information is maintained or within certified health IT that ONC administers, or other types of health IT that may similarly have electronic health information. And so the obligation to make that data accessible, exchangeable, or usable per the statute is the same, regardless of whether or not there's ONC certified health IT involved. We were charged by Congress in relation to the definition of information blocking to identify certain instances where it would be reasonable and necessary in which one of those 3 categories of participants in healthcare could not share information. And so rather than have some type of oversight and enforcement applied to them, Congress recognized that there may be good reason for why they couldn't share the information. So they carved out state law as an example, other types of conditions that we established through what are called exceptions to the information blocking provision that allow for these participants in healthcare to withhold sharing information. We have 2 categories of exceptions, some that I call full stop. So if you have a system downtime event and you're unable to share electronic health information, we've got an exception for that. And that helps you as, let's pretend you're one of those covered actors. That means that you wouldn't be subject to that information blocking enforcement, because you would be able to qualify, in this hypothetical example, you'd be able to qualify for that exception associated with the system downtime, and that you're unable to make electronic health information accessible, exchangeable, or usable, which is that phrase in the statute, at the time that the information is sought after or requested from someone else out there. And so these exceptions are put in place in order to deal with the outlying circumstances where data is unable to be, is unable to move or unable to be shared in certain circumstances. But the general principle around the rule is you should be sharing electronic health information consistent with applicable law. And the important thing to keep in mind from an oversight and enforcement perspective is that there are really 2 categories or 2 classifications here from how investigations would go and then how subsequent enforcement would play out overall. And so for those of you that are familiar with our HHS Office of Inspector General, that office is responsible for investigations. They are allowed to, by statute, impose civil monetary penalties on developers of certified health IT, as well as health information networks and health information exchanges. And they would come in up to $1 million per violation. The second part is related to healthcare providers, where they're also subject to the law. And there's a specific provision in the law that is around appropriate disincentives. And so the department is still going through the policy work around what appropriate disincentives would be relative to healthcare providers. Next slide, please. So this is a brief just heads up, and I'm happy to make these slides available. I know they're part of the recorded webinar as well, but if you'd like a copy of the slides, you're welcome to get a copy of them from the organizers. The who, again, in terms of who's subject to information blocking is listed there. You've got the what in the middle here. So we have 2 dates associated with a gradual phasing in of compliance with respect to information blocking. And it just started April 5th, 2021, so just a couple months ago. And between now and October 6th of 2022, the scope of data that, to say colloquially, cannot be blocked, in air quotes, is around the US CDI. So that gives the actors within the information blocking umbrella a clear set of data that they know is currently in scope for information blocking practices. It gives everyone the ability to adjust, refine their processes, procedures, other types of compliance requirements associated with the information blocking paradigm as a whole, and get familiar with using an exception. And so for data that's outside the scope of the USCDI, I would certainly encourage all of you to act as if the law is applicable to that data, because it will be very soon, within the next year as we look toward October 6th of 2022. Next slide, please. So here's a timeline of the overall mixture between certification requirements, which again, this top half of the timeline is applicable to health IT developers. And so there are things there that you can look forward to in terms of benefits to the overall ecosystem that health IT developers will need to meet. And then the simpler bottom half there is really around information blocking. As I mentioned, we just surpassed the April 5th, 2021 applicability date for the information blocking provisions. Between April 5th and October 6th of 2022, you've got this 18-month window for the gradual phasing in of a larger scope of data relative to information blocking. And then as you flip back up to the certification timeline there, I would kind of cast your attention to the December 31st of 2022. And the reason that I frame the title slide here is there's these applicability dates, there are compliance dates, so certain things kicked in immediately or very soon thereafter for health IT developers, but then there are comply by dates. And so, the date of 12/31/2022 is the last possible date in order to comply, with the requirements. But our experience with the health IT developer community is that they will start to roll out new capabilities over time in order for there to be adjustments and implementation by their customers. And so having that information and that regulatory compliance is not a wait until type of thing. And so we expect certainly in the second half of 2022 that these new capabilities that are required by the rules will definitely be seeing the light of day in greater proportions. All right, let's go on to the last slide here related to the cures rule. In case you need additional resources, please feel free to check out healthit.gov/cures rule. There's a wealth of FAQs, fact sheets, we record webinars. So if you're looking for anything related to information blocking in particular, please go to this website first. Make sure you share it with your friends and colleagues and make sure that they're aware of all of the various different resources that we have available to you to help. And if you do need additional help or you have other questions, there are links to get you to places on our website where you can ask questions and submit information blocking related inquiries as well. And if you happen to be subject to an allegation or alleged information blocking, there are ways for you to do that and report that into ONC equally as well. So let's turn over. I want to make sure that we leave enough time for some questions and talk about, what's cooking, what's happening in the health IT space. And so first I wanted to reflect on some, you can go to the next slide, some COVID-19 observations. It probably goes without saying that long-term planning is important, but I do want to emphasize, now that we're appearing to emerge, and hopefully getting back to a new normal, that, as we as a government, as we as a nation have invested a lot of money in, recent legislative activities, as Congress has poured lots of money into the economic recovery and the public health response, long-term planning is important. We've been through, and I've been through, different cycles in administrations where we had a cycle of response around Ebola, and everyone was worried about that for a particular time. And we had a cycle of response around Zika, and that was another worrisome time from a public health investment perspective. And so as you all, especially in New York, have made investments in your public health response, looking out into the future and starting to chart the course for what type of planning is necessary, be it, West Nile, I remember, is one of those things that happened in New York. There have been various other public health related responses. It doesn't need to be a pandemic, fingers crossed, but we do want to make sure that we've got long-term planning in place. And the important thing, as we start to peel back these layers and look at things from a health IT perspective, is to say, where are we going to need a rapid response from an informatics point of view? And so knowing how we want to collect data in advance, knowing the ways in which we want to collect data, those are pain points. And I know we experienced that. We did a lot of detective work with our colleagues at state and local levels to say, how is the data moving? What streams are available? How is the federal government requiring reporting? How are states requiring reporting? Who is the source of this data? And knowing who those upstream data sources are and whether and how they can produce the quality of the data that's necessary for the type of reporting that's expected to inform policymaking, to inform public health. Those are all things that are really important for us to, as we get a chance to take a breath, to take a look back and say, how can we make this better? And so, another thing that I reflect on quite a bit in terms of the power of technology and the power of health IT is around the workflow. And how do we make interoperability that people can feel the difference in? And so there are tremendous opportunities for, as I note here, fully and semi-automated approaches. As I lamented in the prior slide, still a lot of faxing going on, still a lot of phone calls, footwork, literal footwork, to move data from place to place. And that's a lot of human labor and a lot of time embedded into the system that hopefully we can look to using technology to enrich and change the way and change the job structures and analysis in which health IT is being deployed, and really aid and provide those insights and other types of work that computers are really good at, and can leave the higher value analytical policy development, kind of bigger picture review to the experts in the field, epidemiologists and other public health officials and the like. So that as you start to think about that, the way in which we distribute clinical knowledge and authoritative public health guidance is another area I think ripe for opportunity. Again, as we experienced it with Ebola and Zika, travel history is really important, and understanding the flow in which we wanted to capture which countries are on the list, at a particular time, distributing all of that out to the clinical community. These are things that we are really effective at doing with computers, but we've got to build that into the process. And we also have to have ways to, publish and subscribe or some other type of modality for authoritative guidance. If, the state of New York is going to issue, certain authoritative public health guidance, we want to make sure that that gets, federated out, distributed out to all of the clinical professionals that may need it. And one way to help, make that happen in an automated way is to have health IT that's built in to be able to receive that type of information as well. And so then lastly, I think certainly through all of our work, and this is a community-wide royal we expression, technology and digital literacy is definitely a scale and something that we have to continue to work on. So being able to explain technology and how it works and what type of reporting is happening, and being able to explain the implications of the data to the public is another important concept, I would say, that we can continue to look at doing as a community better and making insights available to the general public. Let's go to the next slide. And I'll talk about what else is up from a health IT perspective. So for those of you that are into workforce, which is going to be another really important focus opportunity for us as we emerge from the pandemic here, we actually received some money to develop a public health informatics and technology workforce development program through the ARP, which is the most recent stimulus bill that went through. And so that is roughly an $80 million program, and we just put out the funding opportunity announcement. And so I would encourage you to check out that link if you are a part of a organization or folks that work in the training and academic center, the kind of segment of the health IT community, this would be right up their alley relative to submitting a consortium-oriented bid to be part of that workforce development program. And so our hope is to churn out many thousands of new professionals or upskilled professionals on public health informatics. The other one here that I want to highlight for you is a public comment opportunity. We're at the start of a new decade. We have an opportunity to, shoot forward and look toward what are the outcomes that we want to accomplish by the end of the 2020s. And we've started an initiative that we call Health Interoperability Outcomes 2030. So this gives us an opportunity to lay out and receive from the community at large, what do we think interoperability should look like? What do we think interoperability should feel like? What do we think that patients should be able to do, or that individuals should be able to do, or that caregivers should be able to do, or that health professionals should be able to do with interoperability, by 2030. And so this is an open opportunity for anyone. I would encourage all of you to go to the website, pop in, it's a sentence or two that starts with, by 2030. I think this will happen as a result, because of interoperability. Because of interoperability, we're going to be able to do X and Y by 2030. And so please, I would very much encourage you. I'm out here banging the drum to get everybody to submit their outcome statements in. We hope by the late this fall, we'll publish, a version of a prioritized set of interoperability outcomes for 2030 for the nation that ONC wants to help coordinate everyone around. One other thing to call to your attention, which blends in with the whole public health and pandemic response, there was an executive order issued now, several months back by President Biden on public health and data. And so there's lots of ongoing work within the executive branch, and I'm sure, within your agencies or other types of organizations looking at how do we deal with data-driven responses for future high-consequence public health threats, as the executive order is focused on. I already mentioned the Federal Health IT Strategic Plan being issued, but if you want to check that out and find out more about what the federal government, and this is inclusive of 20 plus federal agencies, that's an opportunity for you to see, how federal agencies are approaching health IT and the strategic goals and objectives that we have laid out there. If you're a little bit more interested in research, there's an opportunity for you to check out this policy and development agenda that we have, which frames out a number of objectives for and priorities around health IT and its intersection with the research community. And then lastly, the one thing that came out of the 21st Century Cures Act was a strategy for reducing regulatory and administrative burdens related to health IT. And so we did go through a whole cycle of review, analysis, public comment, and we issued this report and are now on the execution and implementation side of this report and the strategies that were included therein. So that's a brief summary of a few other things that you may want to be keeping tabs on from a health IT and ONC perspective. And with that, we can go to the last slide, which is just our general contact slide. You're welcome to reach out to us via any of those modes. And happy to take questions for the time remaining.
Steve, great presentation. Thank you very much. Very comprehensive. Picked up a lot of good information. One question is, what does the future look like with the new administration as we look going forward? Is there anything else other that we should be aware of, or any other new things that are going to be put into force?
Yeah, you can still hear me, right?
Yes.
Okay. Just making sure the mute button worked if I needed it. So one thing that I would identify that I would say has gained a lot of momentum for us over the past several months since the administration has changed is an acute focus on equity. And I think that blends into largely the space of social determinants of health, among other types of investment areas for health IT and how health IT can have an impact in that space. So you look at, I expand this out and extrapolate this out to a number of different intersecting points. So you've got the opportunity for us to optimize and redefine how health and human services intersect. And so that's going to be, I think, an area over the next, if you look at this administration's first term, that will be things that you will see my office, the rest of the Department of Health and Human Services start to look at how we can start to bridge any gaps that may exist, or to create tighter coupling in health and human services related handoffs and intersections. And so you see a lot of that in the social determinants of health space. Equity as a general matter, as we look at different categories or how we want to stratify that space as a whole, will continue to be an important area of analysis, investigation, policymaking to make sure, this is a digital divide thing. This is making sure that there are, equal access to technologies and the benefits of technology that are deployed in different settings and to different communities that may be underrepresented or under-supported in certain communities. So all of those things, we're looking at now with a greater focus, than we have in the past. And that is, beyond just even last administration, it's certainly gained a whole lot of speed and momentum over the past, year or so.
Thank you very much. I appreciate that. I appreciate you taking all your time. I'm sure all our members will appreciate hearing all the good ones. Have a great day. Thank you very much. If you want to stay on, you're more than welcome to stay on as our next speaker gets ready. And that's Mr. Frank Winter from CMS. Frank, let's get Frank's slide up. And Frank, anytime you're ready, introduce yourself and let everybody know what all the good stuff going on with CMS.
Okay. Hi, good afternoon, everybody. Having some technical glitches today, so hopefully we'll be okay there. I was hoping to show you some websites towards the end, which maybe I can just provide the links afterwards or talk about them a little bit, but we're having a little glitch. So I'm going to start though by just kind of giving a COVID-19 update. Obviously that's been the top priority for CMS. I work in the CMS New York office of local engagement. Of course, we pivoted from, trying, like many did, from trying to address some basic needs in the healthcare system at the beginning of the pandemic and providing flexibility so that staff could move around the country, relocate to deal with surges, flexibility regarding providing care at different sites, waiving certain rules as we do in an emergency to allow care to be provided more efficiently, to then moving on and pivoting because, we're so fortunate to have, very good vaccines available and try and encourage vaccination and start to look forward a bit towards what's coming after the pandemic. So I'm just going to run through, a little bit of our response and some resources you may be familiar with in terms of the current pandemic. My first slide just kind of talks about where you can find information about the waivers and flexibilities that we've issued during the pandemic, updates on those. I know a lot of folks are curious about when the public health emergency may end. We don't know yet. And there are some flexibilities relating to telehealth and I think possibly some others, but most notably some of the flexibilities relating to telehealth that will be extended through the calendar year when the public health emergency ends. So it's possible, could be through the end of this calendar year, possible it could be through the end of the next calendar year. And of course, we'll have to stay tuned. Coronavirus.gov has, the most general information from the government. We also have a new website, wecandothis.hhs.gov, that focuses on our vaccination efforts, encouraging vaccination. New York and New Jersey have passed really important milestones in terms of vaccination. We're hoping that across the country, in July we can, reach the milestone of 70% of adults vaccinated. But in the meantime, we know even as there's a lot of progress, vaccination is uneven across the country. And there are inequities in terms of access to the vaccine, as well as hesitancy from folks concerned about the vaccine. And so we really encourage everyone to get it. And that's why it's really one of our focuses now in terms of our national campaign. We also are very concerned about the amount of care that has been delayed, routine care, during the pandemic. Of course, telehealth and telemedicine have been a great success story, but many folks have still been concerned about getting the routine care, testing, preventive services they need. And this is particularly risky for those with multiple chronic conditions. And so we need to redouble our efforts, towards the end of this public health emergency, as number of cases have dropped, and in many areas of the country, the pandemic has ebbed significantly, encouraging people to go back into the doctor's office, get their routine care, go to see the dentist, et cetera, and get the screenings that they need. And so that's certainly a focus. I mentioned the emergency declaration and its importance. Is just sort of the next slides deal with those and our waiver authorities. We hear a lot. There's so many emergencies declared at the state and federal level. They're different, whether you're talking about New York or New Jersey. Different levels of emergency at the state level, some of which have been dropped, some of which still are in force. The public health emergency at the federal level is still in force again, and we don't know when that's going to be ended. So it's something to keep tabs on, but that is the source of a lot of the waivers and flexibilities. As I mentioned, the goal at the beginning was to provide access to testing, allow providers to relocate to focus on surges, to deal with workforce issues, ensure that there's enough capacity, and increase access to telehealth so people would have an alternative to going into offices when it seemed like it was unsafe for folks to do so. So the CARES Act and also interim final rule that followed expanded telehealth significantly during the pandemic. And in terms of HIT, of course, this is one of the big stories and one of the big focuses of CMS is this has been very successful. And so what can be continued in the future? What should be continued? But also what are there safety concerns, reimbursement concerns? Is telehealth always the most appropriate way for folks to receive care? How important are the fraud and abuse concerns? How important are the concerns from the patient perspective about convenience and appreciating that level of access, especially when we talk about areas where even before the pandemic, there were concerns about transportation and trouble accessing services. So these are all things that we're taking into consideration, and we want, feedback from those in the HIT community, healthcare providers as well. This summer, we're planning to embark on sort of a mini campaign to get more feedback about the future of telehealth services. How broadly will they be covered, under what circumstances? Not all of this is our decision. Some of the flexibilities go away when the public health emergency is over, but certainly Congress is certainly looking at a number of legislative options relating to telehealth. There also is some flexibility that we have under current policy. And so it's really a combination that kind of will sort of tell the future of access to telehealth. We are expecting the proposed physician fee schedule regulation to come out relatively soon. And so that's something to look out for in terms of an opportunity to provide us with comment about the future of telehealth under Medicare. You know, in terms of the expansion during the public health emergency, it dealt with the type of telehealth services, the types of eligible providers, changes in supervision requirements, you know, rules relating to audio-only access for certain types of visits, as opposed to audio and video, which for certain types of care were very important. Another, you know, thing to track, you know, that came out during the pandemic in the public health emergency, new regulatory requirements for critical access hospitals relating to COVID-19 data that came out. Also, regulatory updates requiring labs to report COVID-19 test results in standardized format. On the coverage side, you know, part of our work has been to emphasize to providers that the testing is covered without cost for Medicare beneficiaries, whether it be testing ordered, an initial test not necessarily ordered by a physician or practitioner, and then subsequent COVID-19 tests as ordered and medically necessary, the antibody tests, and the vaccine. There's a great myth still, I know it's hard to believe, but there are some folks who still are very concerned because they've had experiences with the healthcare system of unexpected charges where they are concerned that they're going to be charged for the COVID-19 vaccine. Not only are Medicare beneficiaries not charged, but even those who do not have insurance at all, you know, there is a program through our sister Health and Human Services agency, HRSA, that picks up the tab for the administration of the vaccine. And of course, the vaccine itself has been purchased, you know, at this point by the federal government. At some point, you know, when all the supplies, you know, purchased by the federal government of the vaccine run out, at some point, the vaccine itself may be purchased by providers like other vaccines, and then that would be billed to Medicare and other insurers. But right now, it's only the administration that's being billed. An important IT component to the vaccine has been safety monitoring. This is really, I think, the first vaccine where the monitoring, you know, of adverse effects has gone digital, and that may be why, you know, certainly there's been a lot of reporting of you know, of side effects, of the minor side effects that people can generally expect after getting a vaccine, and certainly COVID-19 vaccine, but other issues that have cropped up, you know, through the process, using, you know, smartphone technology, the vSafe app has allowed for more effective vaccine monitoring, and, you know, really the best safety monitoring of, you know, vaccines that have ever come out. The easiest way for people to make reports and for the CDC to track safety. We are very concerned at this point about, again, vaccine hesitancy. Some folks who are resistant to all or certain vaccines think that the risks of COVID-19 are overstated, or say they're taking a wait-and-see approach. Some say that they're concerned because you know, these vaccines quickly made it to market. Of course, that was an amazing technical achievement and also kind of a regulatory achievement by CDC, as you know, clinical trials were run with the same specifications as for any other vaccine, but they were run concurrently. So, you know, these vaccines are very safe and effective, and we've been trying to get that message out, and to the extent that folks can share information with their friends, families, partners through social media, it's extremely helpful. And we've been focusing certainly in one of the goals of the new administration is addressing inequities in the healthcare system, disparities, and what we're seeing, unfortunately, in terms of vaccination is disparity in terms of who is getting vaccine. Some of that may be due to access issues, some of it's due to hesitancy, but we have both through the website I mentioned earlier, wecandothis.hhs.gov, and also our Office of Minority Health. We have a number of resources and educational materials that you can share that hopefully can address some of the concerns and frequently asked questions that people have about the vaccine. I also want to mention that one of the priorities now is getting folks who may have lost coverage during the pandemic onto health insurance. There's a special enrollment period that was ordered at the end of January 28th, to allow folks to enroll. And we have millions who've enrolled, over 1 million who've enrolled, as I understand it, during the special enrollment period in the federal marketplaces across the country, and state marketplaces like the state marketplace in New York and the state marketplace in New Jersey have followed suit and also have allowed for enrollment throughout 2021. So those who may have lost employment and during the pandemic and need health coverage will be able to enroll. Just at the end here, I've included a number of different resources relating to COVID-19. I also want to mention some of the work we're doing with our eMedicare campaign. Some of you may be familiar with Medicare's first app, the What's Covered mobile app, which came out, I believe, in 2019, which allows people to check what services are covered under original Medicare. But Medicare also has a list of apps through Blue Button 2.0 that essentially have met high standards of the Medicare program and by CMS to use with patient consent Medicare data to use as a personal health record, to help make choices about health insurance coverage for research purposes as well. If you go to Medicare.gov, you can find the applications that are approved for use with the Medicare Blue Button data. And we continue to encourage developers to think of creative ways to use that Blue Button 2.0 data. And this only supplements, what was included in the interoperability rule that came out in March 2020, and now is sort of we've come out with a follow-up proposed rule this year on some of the requirements for health plans, both in Medicaid and CHIP, and also Medicare Advantage, as they provide healthcare providers with easier access to requesting prior authorizations. That's the goal, providing Medicare beneficiaries and information about better information via potential apps through requiring the creation of APIs that would allow them to have better access to the coverage provided by their Part D plans, pharmacies participating, healthcare providers participating in Medicare Advantage and Medicaid and CHIP, and a number of other APIs that essentially will provide folks who are enrolled in our programs with more information to take charge of their health care. Because we still, I think, that still is the goal, is really having patients have ownership of their health information. We are also upgrading on Medicare.gov. We have a plan finder. I've had that for many years that allows beneficiaries to make comparisons, of what their coverage options are under Medicare. We are when we made a significant upgrade a couple years ago that linked the information on that plan finder with the Part D data that's in the beneficiary system, so that they could, get an estimate of their potential drug costs with their Part D plan without actually having to enter in all their drugs and dosages. They could just verify the list based on the data that we already had. There are other plans in the future to upgrade Medicare's Plan Finder going into this fall's enrollment period. So that's something to keep track of as well. Let's see. I do want to highlight a couple of other resources online that you may want to check out. We will share these links after the session with Tony. First of all, for folks who haven't been to our webpage for our Office of Burden Reduction and Health Informatics, there's a series of webinars coming up this summer that focus on some of the new API requirements, how to comply. They're designed for developers, tech experts, analysts, on meeting the new requirements, testing under the FHIR standards, those start, I believe, July 20th, run through the 22nd. There also are some new FAQs about requirements under the interoperability rule on their website, which I encourage folks to check out. As you may know, the implementation deadline for some of the requirements under the interoperability and patient access rule was July 1st. It was delayed to July 1st of 2021. So that's right around the corner. So of course, that's something also that we're tracking. In terms of the proposed rule that came out earlier this year, that sort of puts a finer point on things and some of those requirements. And so of course, folks should be familiar and take a look at that. I'm going to be sharing with Tony after the session an invitation for an event we have next week with our Center for Medicare and Medicaid Innovation. Hopefully some of you all have attended in the past our annual innovation days that we've held out of our CMS New York office, which highlight some of the Center for Medicare and Medicaid Innovation's programs and priorities, but also priorities at the state level. For many years, we focused on DSRIP at the state level, along with some of the great work being done in New York City through the Department of Health and Mental Hygiene. Of course, now we're sort of, there's a lot of talk among our partners about post-DSRIP, where to go next. Of course, some DSRIPs have some leftover funding that they're spending, and so it's kind of interesting how this has evolved over the years. But the session next week on Monday at 11 a.m. will feature the Deputy Director of our Center for Medicare and Medicaid Innovation, talking about the priorities of the Innovation Center, and we'll also be following up with some subsequent sessions that will look, as we have in the past, at innovation at the state and local level. So I encourage folks, as I said, I'll forward Tony the invitation. I encourage folks to consider registering if you're interested, because I think the intersection between some of these delivery system reform programs and HIT has always really been important. I think some of the future sessions coming up this summer may also be of interest. So with that, I know that was a kind of a laundry list of different topics for you, and I hope I didn't lose you too much without the visual there, as I mentioned some of our websites, but happy to see if any folks have any questions or comments at this point. Thanks.
Frank, thank you very much. Very good presentation. Lots of good information that's available. Right now, we don't have any additional questions that I can see. But I will take you up on your offer to that event for next week. We'll go ahead and publish it out to all of our members, and those that are able to make it, I'm sure we'll be able to join. Again,
thank you, Tony.
glad.
That's great. And I'll send you the other links that I mentioned just in case folks are interested.
Terrific. I appreciate that. And we'll go ahead and push it out there. And again, Frank, thanks for your help in getting ONC also for this particular session. We appreciate the work that you did to try to help our chapter and our members out. For those that are on the phone, just a couple other little things. We had our election, and the election results will be published shortly, so we'll see the new members on our board. And we also have completed our scholarship program. So we have 4 winners, both in the undergrad and the graduate programs. So we'll be sending out information to those winners as well. Look for our emails, social media coming shortly. We have a couple of good events coming up in the month of July and August as well. So we'll try to keep everybody informed on what's going on in healthcare now and in the future. We appreciate the attendance for the folks. And again, we thank our producer, Nick, in the background, making sure everything was put up. And have a great day, everybody. And please join us for our next events. I think we're doing a good job in putting all this good information together. Frank, thank you again. And we did thank Steve earlier today. So everybody have a good day. And we'll end our session on a high note.